Hi, Blake.
Hello.
How's it going?
Good.
Okay, so we are just going to get started right at 12. We'll let people filter in while I do some housekeeping. So thanks everyone for joining us today. Of course, my name is Stephanie. I'm the research coordinator for the GCI. Before we get started, I'd like to just take some time to acknowledge the traditional unceded territories that we're each gathered on today. So for myself, I'm in the Fraser Valley, and those are the territories of the Coquitlam First Nations, which lie within the shared territories of the Tsleil-Waututh, Katzie, Musqueam, Kikite, Squamish, and Stolo nations. So as always, I'd like to just encourage everyone to take some time and think about the territories which you're joining from today and how that impacts the work that you do. So next we'll jump into some very brief housekeeping. So as always, please try to make sure that your microphones are muted, especially throughout the duration of the presentation. We'll welcome everyone at the end of the presentation to turn on their microphones and their cameras if they're comfortable, and we can ask questions and stuff at the very end. Also please feel free to keep your cameras on throughout the duration of the presentation as well. And of course, please feel free to use the chat function to have discussions among the group, and as well as to put your questions in there. And next, I'll just introduce everyone to our speaker for this week. So today we have Dr. Blake Gilks, who is a professor in the Department of Pathology and Laboratory Medicine at UBC, and he also does clinical service work in the Division of Anatomic Pathology at VGH. Dr. Gilks leads a research program focused on gynecologic cancers and is the co-founder of the Genetic Pathology Evaluation Center, a laboratory that uses tissue microarrays of human tumor samples for cancer research, and OVCARE, a multidisciplinary team studying gynecologic cancers. So Dr. Gilks, I'll let you take it away, and yeah.
Thank you very much, Stephanie. So today's topic, the World Health Organization 5th edition of classification of tumors of the female reproductive tract, what's new? And thank you for the invitation back after presenting earlier in the summer on vulvar cancer. We recently had the pleasure of interviewing Dr. Steven Silverberg, who retired after 50 years as a full-time gynecological pathologist, president of our society, editor of the International Journal of Gynepath, and asked him to think about what were the most important discoveries of the last 50 years in the field of gynecological pathology. So he surveyed a bunch of colleagues, and these were the top two: discovery of the role of HPV in the etiology of cancer of the lower genital tract, and that was the Nobel Prize to Harold Zerhausen, the introduction of vaccines, hugely impactful research. Number two was an interesting one, though, perhaps a surprise to many people, and it was the emergence of international classification systems for gynecological cancers. And that's what we're talking about today. So prior to these systems being introduced, people sort of made up names. There were a lot of eponymous designations. We named things after people. It was thought that that would be a good thing to do, like naming streets. All of that's changed now with these international consortia. And the one we're talking about today is a series of books sponsored by the World Health Organization, and the publication center is based in Lyon, and you can access them online. The 5th edition, Female Genital Tumors, came out this fall, and it's always exciting to see what's new in classification, and that's what we'll do today in the next 45 minutes or so. So a lot of differences from the first edition, although it was not that long ago. It's gotten bigger. There's a lot more information in it. And it has now the effect that you can put twice as many bottles of wine on the cover. So this demonstrates scale nicely. Those are not my bottles of wine, they're Joe Rabin's. He has much more refined taste than I do. Let's start with ovary. So it's actually largely unchanged from 2014, the fourth edition. One of the big breakthroughs in the fourth edition was the recognition that the 5 main ovarian carcinoma histotypes, high-grade serous, low-grade serous, endometrioid, clear cell, and mucinous, differ with respect to precursor lesions, risk factors, genetic events during oncogenesis, immunophenotype, patterns of spread, response to chemotherapy, and patient outcomes. That is, for different diseases. Furthermore, they should be reproducibly diagnosable in practice. And in the last 6 years, we've seen this where you have different hereditary cancer screening practices, different treatments, different clinical trials for the different histotypes. So we are now treating them like 5 different diseases. Mixed carcinoma reappeared. It had disappeared in the fourth edition. It was overused up until the fourth edition. What happened at 2014, it was felt was an overreaction. To take it out completely was not right. They do occur, but they're rare. And they're usually tumor types that are seen in association with endometriosis. So admixtures of, for example. And some rules about how to diagnose mixed carcinoma in practice are provided. But the important point is that most carcinomas, which might look mixed in terms of the cell type from a light microscopical point of view, they're a single clonal neoplasm, and the morphological variation reflects underlying intratumoral heterogeneity. We know that high-grade serous carcinomas in particular are chromosomally unstable. And nice work done by, it's led by Saurabh Shah in Vancouver. If you took 4 samples from one patient, only 50% of mutations would be present in all 4 samples. There's that much divergence as these tumors progress. So it's not surprising that we see the morphological counterpart, which is a lot of intratumoral heterogeneity when we look down the microscope. But that's not a mixed tumor, that's still a high-grade serous carcinoma. So the pendulum maybe swung a little bit, has swung a little bit too far in 2014, come back now, and I think we have it right at this point. We have some rare, recently recognized ovarian carcinoma variants, and they're of interest to the research community. The mesonephric-like carcinomas, dedifferentiated carcinomas. Just because they're rare doesn't mean they're not critically important for the patients that have them, and our lack of understanding of the molecular underpinnings means that these are very attractive tumors to investigate for researchers, because you go from knowing nothing to hopefully uncovering targetable abnormalities. A difference that doesn't seem big, but maybe we'll talk about for a minute because I think it is, carcinomosarcoma. It's a tumor that shows both epithelial and mesenchymal differentiation. It's now considered a carcinoma variant. Well, who cares? What difference does it make? Well, for a long time, they were considered a sarcoma, classified with sarcomas. That had a couple effects. They were treated like sarcomas, and we know that the high-risk tumors that we call carcinosarcomas actually respond to chemotherapy more like carcinoma now. So that was, we were misled into incorrect treatments. But perhaps the most important thing was that they were ignored, not entered into clinical trials. We didn't learn as much about them as we perhaps could have, because they were orphaned a bit. They were off on their own. Carcinosarcoma is much more common in the endometrium, but the same problems have plagued carcinosarcoma of the endometrium. When I was a medical student many years ago, we were taught that these tumors, carcinosarcomas, or malignant mixed mesodermal tumors, or malignant mixed Mullerian tumors, the old names, uniformly fatal. That's not true, of course. We do have more effective treatments. There's still a high-risk type of uterine or ovarian cancer, but there has been progress. And interestingly, one type of carcinoma from 2014 doesn't exist anymore. It became clear on further investigation it was so closely related to endometrioid that it's considered a variant of endometrioid carcinoma. So just as in the phylogeny of animals, you might have a new tree kangaroo species emerge through further study, or two groups that were considered separate species be merged on closer examination. The same has happened with tumors. Oops, this slide was supposed to have disappeared. And what has happened from 2014 to 2020 is it's now accepted that most high-grade serous carcinomas arise from the fallopian tube. And serous tubal intraepithelial carcinoma is depicted here and here with high proliferation index and abnormal p53 staining. Hard to believe, but as recently as 2014, this was controversial. And we have new criteria published in 2020 for the primary site assignment for high-grade serous carcinomas. And we now consider most of them to be tubal primary site based on these criteria. And that reflects our understanding of the natural history. Almost all incidental early high-grade serous carcinomas are in the fimbrial end of the fallopian tube. And we didn't know that even 6 years ago. We have genetic variation in Sertoli Leydig cell tumors with 3 molecular subtypes. The ones with DICER1 mutations could be a hereditary DICER1 syndrome, younger patients, and they're more poorly differentiated. Older patients with FOXL2 mutated tumors. And finally, a group that have neither FOXL2 nor DICER and are of intermediate age and histological features. So that's it. No major changes, as we heard about for vulvar cancer when I presented in June, or we'll hear about today for cervical cancer, and some refinements in our understanding of high-grade serous cancer and the molecular pathology of sex cord stromal tumors. What's new for endometrium? And I think it's similar to what happened in 2014 for ovary. Endometrial cancer is not a single disease. Since 1983, we've recognized type 1 and type 2 endometrial cancers. Type 1, younger patients, high BMI or other source of excess estrogen, very favorable prognosis, mostly endometrioid cell type. Type 2, a decade or more older, unrelated to estrogen and a poor prognosis. And these are the histotypes in the WHO in 2020. This is an endometrioid tumor recapitulating normal endometrial glands, but with crowding and cellular pleomorphism and mitotic activity. And then a serous carcinoma with more stratification of the cells, much more atypia and higher mitotic rate. And they have different mutation profiles, P10 mutations in the endometrioid tumors, not in serous PPP2R1A and P53, the serous carcinomas. But none of these mutations are completely sensitive or specific. And in fact, when we try to diagnose the histotype for endometrial cancer, In contrast to ovary, where we can do it very reproducibly, not so reproducible. So 3 pathologists from around the world reviewed 56 consecutive cases of high-grade cancer, and agreement about the predominant cell type by all 3 in less than 2/3 of cases. A huge problem. You can't enter a patient into a clinical trial. You can't have treatments based on histotype. If the histotype is different, if you go to a pathologist on this side of the hall compared to that side of the hall, or if you go from Boston to New York, like the pathologists in this series. And that takes us to 2013. And this data did not get into the 2014 WHO, but it figures prominently in 2020. Based on the genomic alterations, the phenotype of the genome of the tumor cells, there are 4 molecular subtypes of endometrial cancer: ultramutated, hypermutated, low numbers of copy number abnormalities, and high numbers of copy number abnormalities. The hypermutated, so 10 times as many mutations as these ones, have mismatch repair deficiency. They have a DNA repair defect. The ultramutated, 100 times as many mutations, so there's considerable variability. And the ultramutated did very well. All 17 patients alive and well in the TCGA, the Cancer Genome Atlas study. The high copy number abnormality, much worse prognosis. Half dead of disease, 0 dead of disease. These 2 somewhere in the middle. So that was exciting, but not really clinically actionable. You had to sequence whole genomes. This is based on hierarchical clustering. It's not a diagnosis or a diagnostic classification. It points towards one. So 4 distinct groups. This, the copy number low, would correspond to the type 1 of Boquin. Copy number high, the type 2. But it's this group here, 30% or even slightly more of endometrial cancers that didn't fit into type 1 and type 2, and why the type 1 versus type 2 really didn't work as a classification system. It's too complex. It's 4 different molecular subtypes. So these were clusters, but the mutations actually, again, they weren't completely specific. P10 mutations in these 3 clusters, relatively few in this. We knew that, the serous are less likely. TP53 in the high copy number group, but also in some of the others, including the ultramutated. Polymerase epsilon, which we now know is the pathogenic driver of these ultramutated tumors. But you also have mutations in polymerase epsilon in other tumors. What's going on with that? So there's not a single genetic marker that will substratify based on these genomic subtypes. So what we did is try to develop a classifier that could be used in routine diagnostic practice. And we followed the Institute of Medicine's guidelines, where you go through a 3-step process. And this is to avoid false discovery, avoiding treating patients based on results that are spurious. The genomics-based discovery platforms are very powerful, but there is the risk of false positive results. And this avoids that by locking down your test and then taking it through a series of validations. And only when you cross this line after 3 validation sets could you consider using it in a clinical trial, for example. So this is the process. And this process, like so many processes, came out of an unfortunate experience that we learned from the early days of genomic classifiers. So we looked at multiple markers for each of the different groups, the 4 different molecular subtypes, and we paired them up in different ways, combined them in different ways so that there were 16 models tested. We wanted to look for ability to discern outcomes and their applicability in clinical practice. And what you see, this is Herald's C index. The higher the bar, the better the prognostication. When you combine it with clinical features like ESMO or pathology parameters, they perform best. But this is what we settled on. So this is just clinical. This is the clinical classifier to pick out the molecular subtypes: mismatch repair deficiency, polymerase exonuclease domain mutations, and p53 immunostaining. And that is the classifier that we've settled on, the Promis classifier, so-called, for proactive molecular classification of endometrial cancer. And these are the now accepted terminologies that you see in WHO 2020 for the 4 molecular subtypes. No specific molecular profile is now accepted. So 1, 2, 3, 4. An interesting thing happens. These are only 15%, but they account for more than 50% of deaths. These, not that common, but the patients do extraordinarily well, even with advanced stage disease, lymphovascular invasion, even when there's been recurrence. Most patients have been cured with chemotherapy, even distant recurrence. Almost unheard of biology for these ultramutated or polymutant tumors. And this is the data from the confirmation cohort, collaboration between folks in Vancouver and Germany. And you can see the red line for p53 abnormal way down here, and the ultramutated way up here. Progression-free survival, 1 event. Disease-free survival, 2 events. Overall survival, of course, age takes its toll, but still showing this incredible ability to prognosticate, such that independent of molecular subtype, histotype was not prognostically significant. We then went ahead with colleagues around the world, combined case series from clinical trials from different centers to look at a specific subtype of endometrial cancer. Between 5 and 10% are this high-grade endometrioid type. We have no way of substratifying this group up until now. So we had cases from the Netherlands, from British Columbia, New York, Spain, Massachusetts, and the UK. And this is the breakdown. We had 400 cases by combining cases. 12% polymerase epsilon, p53 abnormal, 18, both higher than in a population-based series. Mismatch repair deficient is actually the most common. In a population-based series of endometrial cancer, the NSMP are the most common. Different stages of diagnosis, so a well-powered retrospective study. Molecular subtype is associated with overall and relapse-free survival. So these very familiar curves with the p53 abnormal here and the poly mutant here, mismatch repair deficient NSMP in between. And even for stage 1, you get stratification that's significant based on the molecular subtype. So very impressive ability to stratify patients even within a group that was not previously subdivisible. Clear cell carcinoma is another group that was not subdividable, but what we have is that about 1/3 are p53 abnormal. They have the worst outcomes. The p53 wild type or NSMP, similarly relatively poor outcomes. And then the MMRD or mismatch repair deficient and polymerase epsilon behave as you would expect for any mismatch repair deficient or polymerase epsilon tumor. Histotype doesn't matter within those 2 groups. So the p53 abnormal behave like p53 abnormal, mismatch repair deficient, polymerase mutant, respectively, like their molecular subtypes. And what's left is this small group, about half of what we would have called clear cell, that are a distinct tumor entity. But this is when things change. And this is a study from earlier this year, came out in Journal of Clinical Oncology. And they took the cases from the PORTEC-3 clinical trial, intermediate high risk, treated with combination, randomized to be treated with either radiation alone or radiation and chemotherapy. Well, polymerase epsilon, no difference. They both did splendidly. P53 abnormal, though, a huge difference, a survival advantage associated with chemotherapy. In the mismatch repair deficient, there was no survival advantage with chemotherapy. It's not a prospective clinical trial with a pre-stated clinical hypothesis, but it's an ad hoc, post hoc analysis of a clinical trial data set of a large, well-designed clinical trial, and a huge difference in terms of the number of patients needed to treat to save a life. And that's what we're looking for. This is a huge, huge difference with the curves separating and staying separate. So, and this is just with standard chemotherapy that's given all the time, for example, for ovarian cancer. So it's a very easy treatment to envisage for this subset of endometrial cancers. It also explains why the clinical trials of chemotherapy in the past have been difficult to understand. Sometimes a result seen, sometimes not. In the past, they would have been an admixture of patients who would not be expected to have a response because they have hypermutated mismatch repair deficient tumors, and patients where we do see a response, P53 abnormal. So lots of opportunities for new treatments and multiple clinical trials, prospective clinical trials coming out of that to give the highest level of evidence to support changes in patient care. Back to polymerase epsilon. When polymerase epsilon is mutated, you get characteristic changes in the genome. And this is the phenotype of the genome associated with polymerase epsilon mutations. Very high tumor mutation burden, greater than 100 per megabase. And the single nucleotide changes are very characteristic. And there's very few insertions and deletions. It turns out that this set of changes in the genome is only associated with, consistently with these mutations. These are the pathogenic ones. In fact, these two mutations account for about 75% of poly mutations. Functional studies have shown that it's not simple. It's not just the loss of exonuclease function. There's also a gain of function. The polymerase activity is more rapid. They process along the DNA strand more rapidly, and that we think also contributes to the very high error rate. The mutation rate is so high that they're on the cusp of non-survival. They're almost ready to undergo spontaneous death because of the very high mutation rate. We also think that's why the outcomes are so good, even with distant metastases. But you have to sequence exons 9 through 14 to look for those 11 hotspot mutations. Mismatch repair staining can be done by immunohistochemistry, or you can look for microsatellite instability. Mismatch repair enzymes, if you lose function, you get errors which particularly are prone to happen at microsatellite or nucleotide repeats within the genome. So these microsatellite unstable tumors are the hypermutated tumors. And we tend to pick them up with immunostaining. Here's Dr. Henry Lynch, who died this past year, one of my heroes, and my daughter and a friend. And he's really the father of this whole field of hereditary cancer. And we have our trick question for you. Henry Lynch is credited with the first description of Lynch syndrome, hereditary breast and ovarian cancer syndrome, both of the above, neither of the above. Now, if you haven't heard of them, there's only two relatively common autosomal dominant hereditary cancer syndromes, and these are them, A and B. Both affect the female reproductive organs. Henry Lynch is credited with the first description of hereditary breast and ovarian cancer syndrome. He, in a sense, rediscovered Lynch syndrome. It had been described by Wharton at the University of Michigan over a century ago, but he rediscovered it in his practice in the 60s and devoted his life to studying these hereditary cancer syndromes. And when we talk about Lynch syndrome, that is associated with mismatch repair gene germline mutations, hereditary breast and ovarian cancer syndrome, most commonly associated with BRCA mutations, BRCA1 and BRCA2. So here's normal retained expression. Here's loss of expression, not in the benign cells, but in the tumor cells. And this is a mismatch repair deficient tumor. Most of these are somatic events, but some will be germline and associated with Lynch syndrome. P53 immunostaining is the other part of the classifier, and it correlates very well with mutational analysis. Ultimately, though, you can do mutational analysis or immunostaining. The cost of sequencing is coming down. They'll probably be the same cost soon. But you have a very equivalent performance. So out of these cases, 84 abnormal, 31 normal, 6 where there is disagreement. When we looked more carefully at these tumors, we thought some were a false negative for sequencing where the deletion was not picked up because there were so many normal cells in the sample. Some were a false negative result for immunostaining where it gave a normal pattern, but there was clearly a mutation present. So if we compare immuno against mutation, this is a sensitivity and specificity, but when we look more carefully, we're basically seeing equivalent performance. And gratifyingly concordant performance independently in different hospitals on a simple quality assurance exercise as well. And here's complete loss pattern.
Mismatch repair and
Oops. And here's overexpression pattern. Little voiceover there, sorry about that. So the last thing to sort out, to use this in clinical practice, you have to have a way of handling tumors that have more than one of the molecular abnormality. You look at POLE, mismatch repair, P53, what if they have 2 or 3 of those? And in fact, that happens in 3% of cases. Well, it turns out that the mismatch repair deficient P53 abnormal tumors have the same outcome as mismatch repair P53 wild type staining tumors. Okay. This is true for all stages in stage 1. They don't have the poor outcome of P53 abnormal tumors. Same with POLE P53. So these tumors where P53 is abnormal, but they also have a mutation in the exonuclease domain or POLE or mismatch repair deficiency, they tend to look like one of these types of tumors. And these are probably secondary events. When you have a hypermutable state, you get a lot of mutations, and it becomes very hard to know what's driving tumorigenesis. The important thing is they behave like POLE mutant or mismatch repair, not like P53 abnormal tumors. And then it turned out that the reproducibility far superior to histotype. And this is the very first attempt at reproducibility, whether it's biopsy versus hysterectomy or interlaboratory and interobserver reproducibility. Kappa statistics between 0.8 and 1 are considered excellent agreement, far better than what we see for light microscopic subclassification. So this is now entering clinical practice slowly. And it turns out that tumors that we thought were of one type, like low-grade endometrioid, are actually a mixture of types. This is most striking for this group, the high-grade endometrioids. It's actually true across all of the histotypes, that they are comprised of different molecular subtypes. And this shows how type 1 and type 2 relate to histotype, and then to the molecular subtypes here. And that's the big change in WHO 2020. 4 molecular subtypes: carcinoma, or carcinosarcoma, as for ovaries, now a subset of carcinoma, and a couple new rare tumors. Move on to uterine mesenchymal tumors. So just 2 more sections. In 2014, this group of tumors here, and Changhan Lee was the first author on the paper describing them. He's at BC Cancer. They just made it into the 2014. They were a brand new entity at that time. High-grade endometrial stromalsarcoma, a new tumor with this characteristic translocation, YWHAE, not M2. And they have characteristic features, and they made WHO 2014, biphasic appearance, an intermediate prognostic group between low-grade endometrial stromal sarcoma and undifferentiated uterine sarcoma. And an in-frame fusion between these 2 genes. It's Dr. Lee, and it's from his fellowship in Boston. The histology, quite unusual. When he was presenting these cases, a number of senior pathologists said, "Oh, I've seen that," and didn't know what to call it at the time. You do see this translocation in other tumors, interestingly. And this tells the story that the cell type, the program of that particular cell type, influences the oncogenicity of a given translocation. So clear cell sarcomas of the kidney are quite different, but they have the same driver translocation. But in 2020, we have a new high-grade endometrial stromal sarcoma. It has an X22 translocation between these 2 genes. It has a more myxoid appearance. It was often misdiagnosed in the past as myxoid leiomyosarcoma, but it does have more aggressive behavior than a low-grade endometrial stromal sarcoma. First 2 cases in 2013, and then Dr. Hong, my colleague at VGH, 3 new cases in 2017. It's rare. We don't know how rare. Until you have a good diagnostic tool, these cases might have been called a number of different things. So we won't know for a while. The illustration of that phenomenon is with the GI stromal tumor. When a good treatment and a good diagnostic marker appeared, it turned out they were 10 times as common as we thought because we didn't look carefully for them. But once you have a new targeted treatment, that made it really important to diagnose it accurately. We had good molecular markers, and it was much more common than we'd imagined. That was a discovery about 20 years ago. So the first 2 cases, actually fairly bland looking, but they are invasive. So these are the tumor blobs here pushing into the myometrium. And again, so infiltration by the tumor, this pale stuff, into the smooth muscle of the uterus. An unusual look. You see why they're called smooth muscle tumors. They are bundles of cells. Bland histological features, but high mitotic rate, often quite focal, the mitotic activity. And an immunostain for B-core, one of the translocated genes. And this is the driving protein, we think, in these tumors. So you can confirm it with molecular typing. Some of them turn out to have B-core internal tandem repeats rather than the fusion fusion between these two genes. So the question facing the group looking at the WHO 2020 classification was where to put these tumors. Do they belong in the endometrial stromal category? Well, it's part of a gene family that is involved in endometrial stromal tumors. JASF1, SUS12, PHF1, all involved in low-grade endometrial stromal sarcomas. The features overlap with other tumors within the endometrial stromal sarcoma category. They're positive for cyclin D1. They have the morphological similarities, upregulation of B-core in common. So the decision was to include them as a high-grade endometrial stromal sarcoma in the WHO 2020. Two other new translocation-driven sarcomas, NTRK, not unique to the uterus, but recognized for the first time as a uterine tumor, as well as occurring in other locations, would have been called fibrosarcoma in the past, but there is a targeted therapy for this. And platelet-derived growth factor beta fusion, fibrosarcoma-like uterine sarcoma, that's usually in the uterine cervix. Again, there's a targeted therapy that can be used, so important to recognize the molecular pathology. This is an example of an NTRK sarcoma. Over here, quite high grade. And the last entity here, something that would have just been called probably a leiomyosarcoma in the past. But it stains with these melanocytic markers like HMB45, melan A, few cell staining. And this is a malignant perivascular epithelioid cell neoplasm, or a PCOMA. Malignancy based on these criteria, and it's now included in the WHO. This has been better defined. In 2014, it was not accepted that it was a distinctive entity. Now it is. This case did have lung metastases. A term introduced by Zamboni in 1996, but it took a while to catch on because there weren't good molecular markers, at least initially. And they have mixed smooth muscle and melanocytic immunophenotype and differentiation. Some sizable series now starting to appear, different parts of the female reproductive tract. And quite variable in their appearance, sometimes clear cell, sometimes more smooth muscle-like, sometimes this more plasmacytoid-like appearance with necrosis. And the melanocytic markers are key to diagnosis. There's HMB45, that's easy. Sometimes though, it's very focal staining as we see here. So still some controversy about diagnostic criteria, but it is emerging as a distinctive entity. And we're out of observational studies developing criteria for malignancy. So the summary of the mesenchymal section. This section, the changes have been driven by the observation of gene fusions. There's a single driver mutation. Often it's targetable, that particular driver mutation, which is important for treatment. And it's resulted in these entities that I've described very briefly today being added, as well as PCOMA, where we don't have a characteristic driver mutation. One I didn't talk about, inflammatory myofibroblastic tumor, where there is a driver and it's ALK. So the last thing we'll talk about is uterine cervix tumors. And what we have in 2020 is a complete departure for adenocarcinoma than what we had before. Rather than cell type based, it's etiology based, and it gets back to the most important consensus, most important discovery in gynecological pathology of the last 50 years, the role of human papillomavirus in the genesis of tumors of the lower female reproductive tract. In fact, what we have here is recognition that not all of them are HPV associated, about 15% are not. In fact, if you look more closely, it's really about 85% this subtype and 15% this subtype. This varies depending on the prevalence of HPV infection. But in the past, we really didn't recognize the HPV independent cervical adenocarcinomas as a distinct entity. Again, it explains clinical trial results. Why did adenocarcinomas do worse than squamous cell carcinomas of the cervix in some clinical trials? Well, it probably depended on how many of these HPV-independent tumors you had. The HPV-associated tumors are radiosensitive, whether squamous or adeno. These are not. And these could account for differences between adeno and squamous if there's enough cases in your series. They would have a worse outcome with conventional treatment. So P16 is the surrogate marker of high-risk human papillomavirus infection. You get strong diffuse overexpression, and that has opened up the etiology-based classification of endocervical cancer, and as I discussed in June, vulvar cancer. So here's an example. Adenocarcinoma. This one's HPV associated with P16 positivity. This is HPV independent. This is HPV associated endocervical adenocarcinoma of the usual type, whereas this is a gastric type HPV independent cervical adenocarcinoma. So a couple quick examples. Here's one where there's high-grade squamous intraepithelial lesion, or HSIL, a precursor lesion of cervical cancer secondary to high-risk human papillomavirus infection. But then we get glandular differentiation. We have cells with mucin in them. And again, and even gland formation with some mucin. So it might have been called mucinous in the past. Another case, and we have these very complex glands, complex glandular outlines going deep into the cervix, well differentiated, abundant mucin. So in the past, we might have called both of these mucinous carcinoma, but the first one is HPV associated cervical adenocarcinoma. This one, which is less mitotically active and less atypical, is an HPV independent gastric type. It is the one with the worst prognosis, doesn't respond to radiotherapy. So in 2020, we're separating these now, and P16 immunostaining is the key tool, or you can look for viral messenger RNA. And some of these gastric types, especially at the advancing edge, look more or less well differentiated. So the summary of cervix, although the majority of endocervical adenocarcinoma is associated with HPV infection, a significant minority, which varies different places in the world, are not. This new classification recognizes this by separating them based on etiology, and it now allows us to focus on not treating everybody the same, but looking for more effective treatments for a group of patients for whom there is a need for more effective treatment, patients with the gastric type adenocarcinomas of the cervix where the prognosis is guarded. We talked about this in June, and again, it was etiology-based classification of squamous cell carcinomas of the vulva. Squamous cell carcinomas of the cervix, almost all are HPV associated, but in the vulva, anywhere from usually around 60 to 75% are HPV independent. the remainder HPV associated. Again, different natural histories, different responses to conventional therapy. So with that, I will stop sharing screen, and happy to take questions.
Thanks so much for the presentation, Blake. Very informative. I'm just going to open up the floor to anyone who has questions. Feel free to unmute yourself and ask away.
This is David Huntsman. Thank you, Blake, for the amazing review. With HPV vaccination programs, they often talk about eradicating cancer of the cervix, but from your presentation, that will be impossible because there's a portion of them which are not associated with that particular infection.
Yeah, they're going nowhere. And same for vulva, that some will be preventable, but the others will persist and may become more common as patients' life expectancy increases. So yeah, there'll remain problems clinically, but it doesn't diminish the impact of being able to prevent HPV-associated cancers, which in some parts of the world are the most common malignancy in women.
Well, I don't see any more questions coming up in the chat. So I think we'll just end off a little early today. So thanks so much, Blake, again for the presentation. We'll have our next presentation 2 weeks from now, the same time at lunch, and we'll be hearing from Dr. Julian Lum about metabolism, immune systems, and cancer. So please make sure you come out to our session 2 weeks from now. And thanks again, Blake, for the presentation. Bye, everyone.
Thank you.